Good afternoon from Miami. This is Dr. John Bennett from cool Miami. It went way down to 65 today. We're broadcasting for Larkin Hospital TV and the Neurosurgical channel today, and we have the pleasure of having Bernardo de Andrada MD, a neurosurgeon from Rio de Janeiro. He's a veteran. He's done 4 or 5 hangouts. Today he's going to do a presentation on herniated cervical discs, and we have a distinguished panel with us today. We'll start with Cynthia. Please introduce yourself, Cynthia.
Hi, good afternoon, everyone. I'm Dr. Cynthia Cadet. I am here in Parkland, Florida, close to Fort Lauderdale area, board certified in emergency medicine. Happy to be here today. Thank you.
Welcome, Cynthia. Glad to have you. And Shajis, can you unmute yourself? Are you there? Do you want to introduce yourself? Or he may be out. Okay, how about you, Simon?
Hello, everyone. It's always a pleasure to be here. I'm a medical student in Tokyo, and I'm also a developmental psychologist. Thank you very much. Looking forward to the presentation.
Simon's the main man of the Hangouts. And Slaven, our connection in Europe. Hello, Slaven.
Hello, everyone. I'm Slaven Gojkovic. I'm a medical student from Zagreb, Croatia, and I'm a member of the Student Society for Neurosurgery, currently doing some projects with students and other professionals in the field of neurosurgery. I'm very happy to be here.
Welcome, Slaven. You're a welcome addition to the team. And Bernardo, it's all yours.
Hello, my name is Bernardo de Andrada. I'm a neurosurgeon from Rio de Janeiro. And thank you, John, for inviting me for talk with you a little about cervical disc herniation. Cervical disc herniation is a very common situation.
I think we have the wrong screen there. There we go.
All right.
We have the HP support. Okay.
So,
okay. There you go.
It's a very common situation, and it causes severe pain, and sometimes it can cause severe disability with motor weakness, and we should treat it surgically or not, and we are gonna talk a little bit about that, when we are going to perform surgery and when not, when we are going to treat just with physical therapy. So let's talk the cervical disc herniation. Usually the nerve root involved is exactly at the level of the herniation. If you have a C6, C7 level disc herniation, your painful root will be the C7. It may cause severe radicular pain. In some cases, it can cause sensory or motor deficit in arms. The involvement of C8 or T1 root may cause a partial Horner syndrome. When you have C4, C5 level involved, there are only 2% of the cervical disc herniations. The root involved is C5. You will have a C5 painful root. You may have a deltoid weakness and shoulder pain and paresthesia. When the herniation occurs at C5, C6, it's 19% of cases. The root involved is C6, and it causes forearm flexion weakness and upper arm weakness, thumb and radial forearm paresthesia. And when you have C6, C7, they are the most common, 69%. The root involved is C7. You can present forearm extension weakness, we call wrist drop, and the finger 2 and 3, and all finger tip paresthesia. When you have C7, T1, it will involve C8 root. We have weakness of hand intrinsical muscle and fingers 4, 5 weakness. You may present the Lermite sign. It's a sensation about electrical shock-like sensation going down the spine. You may present the Sperling sign. It's a manual downward pressures that can cause increase of pain. You can do an axial manual traction, and then the patient will present a relief of pain because we will make the foramen larger and it will present a relief of pain. And when you have a shoulder abduction, the same things happens. You have a relief of pain because the foramens became larger. So how can we make the diagnosis? The main exam is the MRI, is our choice. The accuracy is about 85%, and in the past we used the CT myelogram, but it's a kind of invasive exam, so now we are only use the MRI. In some cases, we can use a dynamic X-ray when we should look for the segmental instability. And if you sometimes want to test the roots, you can use the electroneuromyography and evoked potential. But it's just when you have some doubts about the involvement of the nerve root, which nerve root is involved. You can ask for these exams. So this is C3, 4, 5, C5, C6 large disc herniation with compression of neural tissues, and this patient has a severe cervical root pain that it didn't improve with physical therapy. So these patients underwent the surgical treatment and gets better. It's another case of cervical disc herniation. This case we have a myelopathy here. You have a hyperintense sign at the spinal cord. This patient has a weakness on, has a tetraparesia, has weakness on arms and legs. So the treatment, if there are no motor deficits, we treat these patients conservative. So we recommend physical therapy with cervical traction and non-steroidal anti-inflammatories. I particularly use the ketorolac or ibuprofen. Muscle relaxants like cyclobenzaprine. I used to avoid opioids, and you sometimes may use the steroids in more severe cases. You can use steroids, but and if this patient has persistent neuropathic pain, persistent nerve root pain, you can use a pregabalin. And I recommend acupuncture for the relaxing muscles of the neck, so it helps the patients gets better, improve of the pain. It's really helpful. Over 90% improves without surgery, just with this conservative treatment. But some cases may be recurrent, and we recommend after the patient improves, I always recommend some sports or physical activity like swimming, aquarobics, Pilates, and avoid sedentarism to avoid another crisis, and strengthen the neck of muscles, and always pay attention of the labor conditions of these patients, because a lot of patients has another crisis because they continues to work with heavy weight. So we should always pay attention for the labor conditions of the patients. And when I recommend the surgeries, when you have motor impairments, some motor deficit, radicular weakness, or myelopathy, when we have failure of the conservative treatments, or when you have a recurrent pain crisis, or when you have the segmental instability, because in this case, the patients will present a persistent pain. So we recommend the fusion to treat this persistent pain. We always look for segmental instability of at the dynamic X-ray. It's an X-ray of the cervical spine in flexion and extension situation. And there we are going to look for the segmental instability. So the most used surgery for the cervical disc herniation is known as ACDF, the anterior cervical discectomy and fusion. This is the main approach because it's more used because it's easy, it's safety, and you work inside the disease. You can perform a direct decompression. The posterior decompression you use just sometimes when you have more than 4 levels, when patients has a severe carotid arteriosclerosis, because you may increase the risk of stroke when you handle the anterior cervical neck. So the most used approach is the ACDF, is the anterior approach because it's easier. This is the anterior approach, the cervical plates. I will show you how it works. So ACDF, you perform when you have 1, 2, or 3 levels. You can do 1, 2, or 3 levels discectomy with safety. You can ensure better stability to the cervical spine with the anterior fusion, and you have better outcomes. And when you need to do a posterior laminectomy, only when you have a multiple level disease or when you have a severe cervical stenosis, when you have a stenosis caused more about the ligament flavum hypertrophy than the cervical anterior herniation. So you can use the posterior laminectomy, but it's a kind of indirect decompression. It's not a direct decompression like a CDF. So some complications of the cervical approach. The more serious I think it's the esophageal damage, because you can the patients can acquire a severe infection. So I always take care about the esophagus, and you should avoid vascular damage. You have the carotid and vertebral artery, and you have a jugular vein. Another complication that's very risky is cervical hematome. When you have a postoperatory cervical hematome, you have risk of respiratory failure. So you always should be attention. You always should pay attention of this complication. The infection on anterior approach is rare because the anterior approach, you keep the anatomical plans. So it's different of the posterior approach when you have to cut muscles. In this approach anterior, you keep the anatomical plan, so the infections becomes very rare. It's very common a transient dysphagia, and you should avoid the recurrent laryngeal nerve injury. It can cause hoarseness and vocal cord paresis. Another complication is the weakness of nerve roots, the spinal cord injury. You can be a corticospinal tract weakness. Adjacent level disease is very common too. You have the degeneration of the disc above or under in about a few years because they altered biomechanics. The majority of this condition is asymptomatic. The postoperatory discomfort, you have some patients present this too. CSF leak is not common in anterior approach, and pseudoarthrosis, it's a failure of fusion. It's an anterior approach for 3-level disc disease. You perform the discectomy and you insert a cage at the space of the disc, and you can use an anterior plate fixed with screws to hold the cages to avoid the migrations anteriorly of these cages. It's another case of just one level. We have one cage and the plates holding this cage. It provides the stabilization, and it's another case that we did not use it a plate. We use it a kind of cage that they don't migrate. They don't use to have this situation of migration because they are fixed at the bone. And we have a cervical arthroplasty is another option to treat cervical disc herniations when you have just one or two levels of herniations and you have a maintenance of cervical curvature. You have a maintenance of cervical lordosis. You can use prosthesis. You can use artificial disc. This is the artificial disc. We use anterior approach to do the dissectomy and insert the artificial disc. So this is how it works. And they can preserve the motion. And this is some cases of we have a woman about 62 years old, cervical axial pain, radicular pain, no improvement with 3 weeks of physical therapy. We can observe the dynamic X-ray. We have an instability when you do the flexion in C2, 3, 4, 5, C5, C6 level. We can observe an instability. And there is a cervical herniation with compression of the nerve root with severe painful root, pain on the arm. So in this case we did the dissectomy and the fusion with anterior plates, and this patient has no more pain, improved the quality of life, improves the psychological condition because she was on depression because of chronic pain. And this is another similar case. We did the same thing. And this is another case that we have one ankylosed vertebral body, and we have a disc herniation above and under with compromise of the spinal cord. We have to treat these patients 4 levels by anterior approach. It gets better. And this is another case I just bring to show you that the cervical disc infection, and it caused a cervical spinal cord anterior compression. We did a corpectomy with insertion of a cage to keep the stability of the cervical anterior spine. This is the same case. We removed vertebral body, inserted anterior cage, and fixed with the anterior plate to ensure the stability of the spine. This patient improved. She had tetraparesis and could improve after surgery and use of antibiotics. So you can ask if you have some doubts. It was all.
Okay, Bernardo, thank you very much for another clear presentation with great slides. I guess we'll start things off with Carlos, since he's the only neurosurgeon here on the panel. Hello, Carlos.
Carlos may do this surgery a lot.
Carlos, can you unmute yourself, please? Whoop, I don't know if we're having technical difficulties. One quick question until we get Carlos back on, Bernardo, is when you have a significant cervical disc herniation, do you suggest doing flexion, extension, x-ray views? I would think that might cause some damage.
Excuse me, can you repeat, please?
Yeah, sure. When you have significant cervical disc herniation, would you suggest avoiding flexion, extension, x-rays, or it doesn't really matter? You suggest doing them?
No, I think the patients should do this exam, because it helps on the diagnosis of segmental stability. If
Okay.
this patient has axial pain, persistent axial pain, he may have segmental instability. So we should ask for dynamic X-ray to look for this condition, because this condition improves with the fusion. I'm sure that the segmental stability pain improves with fusion.
Is that considered an emergency? If you have instability to get the person into the operating room as soon as possible?
Excuse me,
Is that
repeat?
an emergency, Bernardo, when someone
No, no,
has?
no, it's not an emergency. It can be an emergency if this patient has a severe neurological deficit,
Okay.
or if the patient had trauma. But if
Okay.
it's just a degenerative condition and the patient has only pain,
Right.
it's not an urgent condition. He can do this exam in a few weeks, or the urgency is the pain. Maybe for the patients it's an urgency.
Okay. Very good. Carlos, you have any comments or questions?
Hello. Congratulations. This was a very didactic presentation, and
Thank you.
I think so. We can analyze about the classification of the degenerative disease of cervical spine. If we speak just about the instability or instability with herniated disc, or we have an instability and myelopathy. So every kind of pathology we must analyze very well, and after that we can decide what kind of treatment is needed for the patient. And I will ask about why you didn't use a neurophysiological evaluation before the surgery. If and the other cases, do you use the intraoperative monitoring in case of severe myelopathy in patients?
So yeah, good question, good question. But unfortunately, in our country, we still beginning to use the intraoperative electrophysiological monitorization, because there are no all insurance that pay for this exam. I understand that it's very helpful for intraoperative intraoperative tests of the neural function, but we still don't have this monitorization for all cases. We have these monitorizations when we are going to do a surgery for a intramedullary spinal tumor, or some kinds of dysraphisms, but just a one level disc herniations, they don't uh, make available the intraoperative electrophysiological monitorization for us. We have to do the surgery without, unfortunately, for
Okay.
me. I
Okay.
think it's very helpful.
Yeah, sure. But we, in the anterior approach, it's not frequent the use of intraoperative neuromonitorization. But in severe cases, when we have a narrow canal, if we have an herniated disc, if we have a severe myelopathy with an tetraparesia, and we need to use the
Yes,
intraoperative
yes, I agree.
neuromonitorization. Yeah,
I agree.
because for example, in the posterior approach, it's normally you must use the intraoperative neuromonitorization, because you must know it's not just an X-ray control. for this kind of surgery, because if you're doing a posterior approach, more.
Whoop, we lost him there. That's okay.
So let me
Go
talk
ahead.
something. When you have myelopathy, just you handle the anterior spine, you can worse the motor conditions of the patients. So the neuromonitorization, I think it's you should use. You know, we are still asking for this exam in the operative home, and I think in a few years we will have these conditions in all surgeries.
Okay.
I was at United States at Phoenix in 2012, and there they use monitorization for all cases of cervical disc herniations. One level cervical disc herniation without myelopathy, so they use. I think it's the correct way, and we think we are asked for this exam in all surgeries, but it's still not our reality, you know.
Okay, Bernardo, could you do me a favor for the students and other people out in the audience that don't know what a monitorization that Carlos is talking about? Could you explain what it is and the approximate cost?
Yes, it's an electroneuromyography and evocate potentials did intraoperative, so you can test the neurological tissues in intraoperative period, you know. So you can, if you may compress nerve roots, they will talk to you. Pay attention at this nerve root is in trouble, so you should look for something. You know, it's helpful for you because you may have a better outcome in postoperative
So
with
it's very
this
expensive,
tool. With
very,
this
very
tool.
expensive machine, Carlos.
No, I think it's not very expensive, but you know, here the
Yeah.
things happens after, you know.
Right. Well, just big hospitals have it. Do they have it?
Yeah,
The big
some big hospitals have, but it's
right,
still beginning here, you
right.
know. It's about 5 years ago we didn't have it in any surgeons, you know.
Okay.
Yeah, it's important because, for example, with the evoked potentials, we can evaluate. For example, in some cases, during the anesthesia, the blood pressure is go down, and we just to know when we see the change in the evoked potentials. That's so it's
Yes.
in a very interesting techniques that it's not possible to use in all surgeries. But if we have the possibility to use, if we can use that, it's better if we do that. And another question is about the complications. What about the complications in anterior approach of cervical disc herniation when the patient shoved an ophthalmos, press the paralysis and the meiosis? What's about that?
No, I don't used to see this complication in my case. I have I just take care about cervical postoperative hematome. I had two cases and it was very bad because you should
Disaster, huh?
to return to the operative room very urgent because the patient has a respiratory failure. But about the meiosis and I don't used to see it a lot. And about you, what do you talk about it?
It's a very rare complication, if, especially when we have a anterior approach for C6, C7, or the T6, T1 disc herniation, because we can produce an stellata ganglion lesion.
Yes, yes, yes.
Okay.
But you know, It's not very common, I think.
Okay, Cynthia, do you have any questions back there in Fort Lauderdale? You're muted, Cynthia.
Oh, okay, here we go. Hi,
Okay.
thank you, doctor, for a very informative presentation.
Hello,
Thank
thank
you.
you for
Um,
attending.
I guess I also have a question regarding postoperative complications. And as far as the rate of non-fusion, how often do you see that where you do the fusion and then it doesn't take, or you have
Yes, in cases of cervical disc herniations, I don't have cases of pseudoarthrosis, that failure of fusions.
okay.
But I had one case. It was on cervical trauma. I did the corpectomy and inserted a cage, and I did the posterior complementation with lateral mass screws. And I have this case. I had a pseudoarthrosis. These patients evaluated with a kyphosis deformations and narrowed canal. So now we are going to approach him again. We are going to remove the cage and do the fusion with the iliacal crest. I, my suspicion is about this case. I used an artificial bone graft, so I suspect that this is the cause of the failure of the fusion. The better is to use the bone of the patients.
Right.
At this case I didn't use. It was not available.
Bernardo, you mentioned that it's an emergency if there's cervical disc herniation with motor deficits. How much of an emergency is it? Do you have to get the patient right to the operating room, or how long does it take before there's damage from a cervical disc herniation with motor deficits?
Yes, it's common when the patient has a chronic disc herniation and suffer for a mild trauma, maybe a car crash. It's not necessary to be a strong energy. Sometimes a mild trauma can cause a tetraplegia or tetraparesia. So I think these patients, you should perform the surgery urgently. But
Okay.
in some cases, they improve partially. They did not return with the previously condition. When you have a chronic spinal disc herniations with chronic spine compression, but the patient is asymptomatic, and someday she drop in the floor or suffer for a mild car crash and can worse rapidly of the neurological status. In this case, we can do the surgery urgently. It's very rare to observe spontaneously anterior disc herniation with tetraplegia. It's very rare. You observe when you have this condition, a chronic disc with chronic compression and quickly worsened, usually followed by a mild trauma.
Okay. Simon and Slaven, do you guys have any questions or comments?
Oh, Slaven, please go first.
Yes, thank you. This was a very interesting presentation, and I think it was very precise, and it gave me some associations. The first one was about an author from the Southeast Europe. He described that a patient who was tetraplegic, he had one day walked up to him after the surgery, a few years after the surgery, and greeted him. And I was curious if this could be even done, because I'm not sure that neurosurgery today is capable of fixing such spinal traumas as complete transection. So can you please comment on the current developments, and if you are familiar more about this, how much can be done?
I didn't understand sometimes of your phrase because it was cutting. Can you
Right.
repeat just the beginning? Sorry.
Okay,
about that.
about the of spinal surgery today? What can be done? Spinal transection.
Oh, so spinal transection.
Yeah, what's the state of the art of the research doing regeneration of a transected cord?
Yes, so when you have a transection cord, you can do the fusion just to the patients be able to do the rehabilitation, to to try the neurological exercises and rehabilitations, but you know that it's just to they can be erected at the wheelchair, you know. Sometimes you have to do the fusion with this objective. It's not to restore the neurological condition because it's still impossible. We hope that
Yes.
someday the stem cells can bring for us some news, but we still only at the researches. We don't have anything concrete in our medical practice.
Yeah.
And when you have this case of spine transections, we usually indicate the fusion just to the patients could do the rehabilitations with safety, without pain, you know, to be in erect position in the wheelchair, you know.
You know, that would be a good topic for another hangout, Slavin, is essentially the state of the art of the research in regeneration of nerves. And there certainly is a lot of people working on it,
So,
Bernardo, all over there's a lot of places working on that.
we sometimes indicate the fusion to the patients could do good rehabilitation without pain, so we can move the head, and but the neurological condition is still waiting for some news of the researchers.
Okay.
You have some experience about the stem cells. You heard something about some news?
Please, can you just comment on this too? Today there was a new treatment, complete transection of spinal cord by the potentials. They would put electricity in the nerve roots below the point of transection, and 5 individuals showed that this treatment helped them along with physiotherapy. So do you know anything about this today? I have heard that this promises.
Yeah, so unfortunately, I don't have any kind of experience in our medical practice with this kinds of the rehabilitation.
Yeah.
We have a rehabilitation center in my city, but they don't do researches. They only treat they get the researches from another centers and do the same thing. So
Yeah.
I don't
Yeah.
know if it's really useful. I know that they are using in some cases the exoskeleton. You know exoskeleton.
Yeah, yeah,
They are
yes,
trying
yes.
to connect with the cortex to if maybe you can do the electrical potential to move the exoskeleton, but it's still evaluating.
Right.
We still
Right.
don't
Yes, yes.
use is you still don't use it in the medical practice. It's far
Yeah.
from our reality.
Yeah.
Thank you very much.
In
Yeah.
some cases, our patients could not do the physical therapy because they live in difficult access places. You know, they are not transport to the rehabilitation center. We still have a lot of social problem. You know,
Right.
so
Yes,
we
yes.
are still a little bit far from this reality,
Well,
unfortunately.
yeah, there's a lot of work going on. In Miami, there's a big center for
Yes.
research. Mark Bonacani Center, you're probably familiar with that, Bernardo.
I
Uh,
hope to visit someday.
yeah, he was a football player that had a transection of his cord. Probably Cynthia and Simon know about him. Mark Bonacani. There's a big center with Barth Green, a
when
neurosurgeon.
I when I had at the North American Spine Society meeting last year in Chicago, I knew a guy that he was at Iraq and suffered from a gunshot and became paraplegic. So he was making donors to the researches of this kind of field of research.
Mhm.
So I hope to be some I hope to have some news
Yeah,
someday.
I think there's going to make tremendous progress in that field
Yeah,
in
sure.
the next 5, 10 years, hopefully. And Simon, do you have a question or
Uh,
comment?
yes, please. Thank you. Thank you very much for your presentation.
Oh, thank you
Uh,
for attending.
Thank you. I have a question, sort of switching gears here, regarding what you said about one case that the psychological condition improved
Yes,
greatly
sure.
after
Good
the
question.
operation, and I guess also conservatively, when you're treating conservatively. But I'm wondering, in the assessment of the patient, is this an important part of your assessment in finding out how they are psychologically? And would you ever prescribe medicines to help them through difficult times?
Yeah, sure. So it's a good question. It's a very important issue. These patients, many cases, they have a chronic pain. So they are chronic suffering, you know, and it's a very common the associations with chronic pain with depression. So it's very common that patients has a depression, a severe depression. So we should evaluate it very well the patients. To we have to ensure they will improve after the surgery because some patients have more depression than cervical herniation, you know. So sometimes you have to treat the depression first to ensure that these patients will improve after surgery. So I had a case that a woman, she was on chronic pain, and after the surgery, she had a psychiatric crisis, you know. She should be hospitalized for treat the psychiatric crisis because he was suffering of pain for years.
Yeah.
And when we treated the pain, it's the first time I saw it. They had a psychiatric arrest, you know,
Wow.
and should be hospitalized. And after they improve, she improved. Sorry, after she improved of the psychiatric condition, which is very important. You have to assess the psychiatric, observe the psychiatric conditions. We
Hmm.
have a very common situation in my country. Some patients, she wants to be operated to have benefits from the government, you know,
Okay. Yeah.
because they they are operated so they can't work. So they
Hmm.
ask for
Right.
benefits from the government.
It
It's a
happens.
very common. So you should avoid to perform unnecessary surgery.
Hmm.
So the psychiatric assessment is, I think, it's one of the main evaluations pre-operative. It's a very important
Hmm.
issue. Thank you for
Thank you. Thank you
remembering
very much.
for this issue.
Thank you.
You know, Bernardo, I guess there's different levels of success with surgery for lumbar disc, herniated lumbar disc versus cervical. I understand that the success rate with operating on cervical disc is a lot higher, generally speaking, than lumbar disc surgery. Can you comment on that, please? And why is the reason for that?
Yes, yes, you are right. The outcome with cervical disc is a little bit better than lumbar. I agree with the indications of the lumbar disc herniations should be more studied because we have some patients improves a lot and we have another patients that do not improve. Carlos know about that, and we should evaluate with very care these patients of lumbar disc herniations because sometimes they don't improve after the surgery. So we should look for instability. we should look for neural compression. I always like to ask for electroneuromyography before in lumbar discs. We should be careful to do not perform unnecessary surgery.
Mm-hmm.
It's very
Very good.
important questions.
Thank you,
And
Cynthia.
I would like to talk about one more thing about monitorization. I
Okay.
was operating a cervical spinal tumor. It's an ependymoma a few months ago, and if I would not have the monitorization, the patients would be tetraplegic. The monitorization send us an alert, so we should look it for what happened. We open it, the dura again, and the patients improve it again. So the suture of the dura was narrow. We should redo it with a patch,
Okay.
So the monitorization is very, very important. I really hope that we have this tool available in all spine surgery someday.
Okay.
Can you please comment on this too? There is a neurosurgeon in Croatia telling us that not any electrocauterization should not be done in the spine, because it should all be stopped with pressure, all bleeding. So can you please comment on this? Is it so easy to injure the nerves?
You are talking about on intraspinal manipulation?
Yes. Electrocautery be done or not?
Yeah, so I always avoid. The last tumor I have operated was in a cervical ependymoma, central medullary ependymoma, and I did all surgery without bipolar coagulation, without. Just with cottons and irrigation, we can stop the bleeding. But sometimes you have some large vessels bleeding, so we use just one little coagulation just to stop this bleeding, and it's well. I think you can use, but you should be very criterious. You should always avoid to coagulate the intraspinal tissues because of the thermical lesions of the neurons, and I avoid to use the aspiration, ultrasonic aspiration. I avoid to cervical intraspinal tumors.
Okay.
Thank you very much.
Carlos, do you have any questions before we close, Carlos? Or comments?
No, thank you. No, thank you very much. I think this was a very good theme and a very good presentation. But I'm so happy.
Thank
you so much, Carlos.
Thank you.
Okay.
Thank
Cynthia,
you,
any questions before we close?
No, thank you very much. Great
Thank you, Cynthia, for attending.
Thank you.
Good to have you with us, Cynthia. And Simon, any comments before we close?
No, as always, wonderful education.
Yeah, Bernie, thanks a lot.
Thank you, Simon. Thank you, John, for inviting me. I hope to be with you again.
Yes, please.
Well, in Rio,
we can talk about spinal tumors next time.
Okay, that would be an excellent topic. One thing they say in Rio, there's only 2 times of the year, before Carnival and after Carnival.
Yes.
Is that true?
Yes. Now we are after Carnival.
After Carnival.
But I don't like Carnival. I don't like Carnival.
I know, a lot of trauma.
Yes, I don't like Carnival.
Okay, Bernardo.
But the most parts of our people likes.
Oh, yeah. Oh, well. Okay, Bernardo, thank you very much once again. And we're going to end this broadcast and hang around after. Thank you.
Thank you.